Our next speaker and last in this session is Carol Langford from the Cleveland Clinic in Cleveland, Ohio. Carol's going to review for us GPA Treatment Choices. Carol.
Well, thank you. I'd like to thank Dr. Cush and Dr. Kavanaugh for inviting me to be here with all of you today to discuss treatment choices in granulomatosis with polyangiitis. My disclosures can be seen on this slide and in your materials. So let's just go ahead and dive on into a question to try and help frame this discussion about treatment. This is a 64-year-old female who's referred to you for a new diagnosis of GPA with active disease involving the sinus, joint, and asymptomatic lung disease with 2 pulmonary nodules that are each about 1 centimeter. There's no renal involvement. So which of the following would be the least preferred option that you would have for treatment? Is it A, rituximab, B, methotrexate, C, mycophenolate mofetil, D, cyclophosphamide, or E, azathioprine? All right, so we're getting a little bit of a spread, but probably the least favored choice here was cyclophosphamide. There we go. So when you're faced with someone who has active GPA, really the first things you should consider is what organs is this affecting and how significantly. This is a patient who has non-severe active GPA. And as you look at the options for treatment, rituximab, methotrexate, or mycophenolate mofetil, all of these could be options based upon the published experience. So that leaves azathioprine and cyclophosphamide. Azathioprine is a good maintenance option, but there's limited published experience for induction. And cyclophosphamide, while an excellent agent that is effective, in this particular setting, the risks outweigh the benefits. And so while we do have these other options available, that would tend to make for me probably cyclophosphamide my least preferred choice out of all of these options. What this case really highlights is the fact that GPA is a multi-system disease that can have a spectrum of disease severity, where we can have organ and immediately life-threatening disease such as alveolar hemorrhage or glomerulonephritis, and at the other end of the spectrum, active but non-severe disease that nevertheless still requires treatment involving organs such as the sinuses, skin, and joint. And this does influence our treatment decisions. Now, the great news is that in 2023, we have a range of options that are available to us, raising the question about what to use and when. And when we think about this, treatment can be thought of as having 2 phases. Induction, where active disease is put into remission, followed by maintenance. And if we look at the induction side of the equation, we further stratify this based upon if the patient has severe or non-severe disease. In the case of our patient, there was non-severe disease present, and while rituximab is an option, there is also data with methotrexate or mycophenolate. Now, methotrexate was actually the first alternative to cyclophosphamide, which was first explored in the early 1990s. And this randomized trial from Europe in 100 patients compared cyclophosphamide to methotrexate and demonstrated that methotrexate was not inferior to cyclophosphamide for remission induction of non-severe disease. Mycophenolate mofetil has also been compared in patients with mild to moderate disease against cyclophosphamide. And although there was similar rates of remission by 6 months, mycophenolate was associated with a slightly higher rate of relapse. But this does provide an option, particularly for patients who may not be able to take methotrexate and would prefer to not receive rituximab. So let's go on to a different patient. You're now asked to see a hospitalized 52-year-old male with a new diagnosis of GPA that's involving the sinus, skin, kidney with a creatinine of 2.5 milligrams per deciliter with an active urine sediment, and lung manifest with ground glass infiltrates on computed tomography who's requiring supplemental oxygen. So in addition to glucocorticoids and consideration of avacopan, which of the following would be your first choice for treatment? Would you use methotrexate, mycophenolate mofetil, rituximab, cyclophosphamide, or a combination of rituximab and cyclophosphamide? All right, well, I think we're getting a pretty clear signal that the majority here would use rituximab by itself, not in combination with cyclophosphamide. So in contrast to the first patient we discussed, this is someone who has severe active GPA, manifest with glomerulonephritis and potentially alveolar hemorrhage. So in this setting, methotrexate and mycophenolate would not be good options as they are really used for induction of non-severe disease, plus methotrexate would be renally contraindicated here, which really leaves the other options. And what I would probably consider was similar to what most of you said, which would be to use rituximab in glucocorticoids, or potentially with avacopan. So again, we're looking at the induction side of the equation, but here a patient who has severe disease where our main options are cyclophosphamide or rituximab. Cyclophosphamide really changed the course of this disease, and while it's very effective as far as remission and induction, and in doing so allowed patient survival, it unfortunately does not prevent the occurrence of relapses. And as became recognized, there were risks of opportunistic infection and serious side effects. The options for remission induction for those with severe disease were really limited to cyclophosphamide until the introduction of rituximab, which was the focus of 2 randomized trials. In the RAVE trial, patients were randomized to either receive cyclophosphamide going to azathioprine or rituximab. These were patients who had severe disease, thereby justifying the use of cyclophosphamide, but the most seriously ill patients were excluded. At the primary endpoint of being in remission and off prednisone at 6 months, rituximab was found to be as effective as cyclophosphamide, and for those enrolled at the time of a relapse, there was a suggestion of even greater benefit with rituximab. There were similar rates of adverse events and infections and a low mortality rate. And based upon this similar effectiveness, this became the basis for FDA approval for rituximab of GPA and MPA in April of 2011. Now, the other randomized trial, which was published in the same New England Journal of Medicine, also compared rituximab to cyclophosphamide, but there were important differences which allowed us to learn several things. All patients received 2 doses of cyclophosphamide before they underwent randomization. And this was also designed as a superiority trial to try and determine if rituximab was in fact better than cyclophosphamide. Now, this was not found to be the case, although it did demonstrate similar rates of remission induction between these 2 agents. There were similar rates of adverse events. There was a higher rate of mortality, including the fact that these were older patients that were enrolled with 20% on dialysis, both of which are risk factors for a poor outcome. So while rituximab was not superior to cyclophosphamide, it did once again appear to be as effective. Now, one thing I have heard about in recently more increasing terms has been, what about combining cyclophosphamide and rituximab? And in addition to the data from the RetuxVAST trial, there have been a number of publications that have examined this regimen, with the main rationale being about the reduction of glucocorticoids, which has been an objective of which we've learned quite a bit more recently. Now, there are significant limitations and concerns with this experience. With the exception of the RetuxVAST trial, most of these were retrospective, single-center, small sample size studies with variable degrees of disease severity and glucocorticoids. Of additional concern was the fact that there was fairly high rates of hypogammaglobulinemia, serious infections, and even mortality. So to my interpretation, the current data does not really support the upfront use of combined cyclophosphamide and rituximab. In my practice, certainly there are instances where I start with one and there is a necessity to go to the other, but I do not generally go in with a plan to combine these up front, and I'll work with the patient in deciding about which to use individually. So in considering as far as which of these choices to use, again, I think there has been significant enough experience that rituximab is used in the vast majority of instances. Certainly in settings of relapsing severe disease, newly diagnosed patients who are each end of the age spectrum, patients with cytopenias, urinary retention, malignancy, or infections. But there are still instances where cyclophosphamide plays an important role. This includes in severe disease in patients with an intolerance to rituximab, potentially worsening severe disease despite rituximab. More controversial is those patients who have fulminant disease, so those who are excluded from the RAVE trial. And interestingly, although there was some discussion about considering this more during the COVID pandemic out of concern for vaccine response with rituximab, it should be noted that cyclophosphamide also suppresses antibody responses. Well, what about relapse after remission induction? And relapses can occur after either cyclophosphamide or rituximab, such that remission maintenance plans need to be considered in every patient. And that really brings us to the maintenance side of the equation, where we can see we have rituximab, but there are also conventional immunosuppressive options. Azathioprine was actually the focus of the first ever randomized trial to be conducted in ANCA-associated vasculitis, and it was compared to cyclophosphamide after cyclophosphamide induction. At the primary endpoint, which was relapse at 18 months, azathioprine was no worse than cyclophosphamide in terms of the rate of relapse. And this demonstrated that this staged induction maintenance approach was able to lessen cyclophosphamide exposure without an increase in relapse rate. Since that time, there have been a number of randomized trials examining different maintenance approaches. In this trial, methotrexate was compared to azathioprine after cyclophosphamide induction and was found to have comparable rates of toxicity and relapse, demonstrating that in patients that were able to take methotrexate, the decision about which of these to use could be made between the patient and their physician. Azathioprine was also compared against mycophenolate mofetil after cyclophosphamide induction. And although there were similar rates of side effects, mycophenolate was associated with a higher rate of relapse. And although this can remain an option in selected patients, this tends to be lower down the list because of this higher rate of relapse compared with azathioprine. Now, the more recent option has been rituximab for remission maintenance, and this has been compared in a number of randomized trials conducted in France. In this first study, the Manritsan trial, rituximab was compared against azathioprine after cyclophosphamide induction, and it was found at the primary endpoint of major relapse at month 28. The rituximab was associated with a far lower rate of relapse as compared with azathioprine. In an important long-term study at month 60 follow-up, while rituximab was still superior, 42% had relapsed after treatment discontinuation, demonstrating that rituximab was more effective than azathioprine to maintain remission, but relapses still occurred after treatment was stopped. Another randomized trial examining rituximab for maintenance compared once again against azathioprine, but this time after rituximab induction, similarly found rituximab was associated with a lower rate of relapse. While there was a similar rate of serious adverse events, hypogammaglobulinemia was seen, and in the long-term follow-up at 48 months, while rituximab retained its superiority, 50% of patients relapsed after treatment was stopped. Once again, demonstrating superiority to azathioprine, the fact that relapses occurred after treatment was stopped. And although this trial utilized a dosage regimen of 1,000 milligrams of rituximab every 4 months, this did not demonstrate that this dosage schedule had a sustained effect of prolonging remission after treatment was discontinued. So in terms of the choice of agent for remission maintenance, rituximab, as mentioned, has been shown in 2 randomized trials to have a lower rate of relapse compared to azathioprine, with the largest body of data utilizing a dose of 500 milligrams every 6 months. But the main problem remains: relapses occur after rituximab is stopped, and the duration of rituximab treatment remains unclear. Concerns remain for toxicity with longer-term use, particularly hypogammaglobulinemia, and as we've seen, there is an impact on vaccine response. So one of the questions that often comes up is whether conventional agents such as azathioprine, methotrexate, or mycophenolate still have a place in maintenance, and to which I think the answer remains yes, after risks and benefits are weighed. The disadvantage is the higher rate of relapse compared to rituximab, but these are well-known therapies that have an established long-term side effect profile, such that in shared decision-making together with your patient, there may be times where a conventional agent may be preferred. Now, what about duration of remission maintenance therapies? Although most clinical trials are based upon 18 to 24 months of maintenance, as we all know, this is not a 24-month disease. And with either rituximab or conventional agents, the rate of relapse is higher off of treatment than on, such that maintenance beyond 24 months may be appropriate in many instances. So what I tell patients as far as is that in the absence of toxicity, they should plan to be on a maintenance regimen for 2 years, after which time we consider together where to go from there, weighing in their relapse history. The presence of organ damage particularly is important, so if someone has had renal insufficiency, that's someone I get nervous about taking off of their maintenance treatment. Toxicity, then of course patient preferences, compliance, and family planning. I do want to touch on the plasma exchange trial. The Pexavas study was the largest trial to be conducted in ANCA-associated vasculitis to date, enrolling 704 patients with severe disease. This study sought to examine the role not only of plasma exchange, but also of a reduced dose glucocorticoid schedule, looking at the composite primary endpoint of end-stage renal disease or death. When examining plasma exchange, this was not found to reduce the risk of end-stage renal disease or death as compared to those who did not receive plasma exchange, although this may not rule out the possibility of benefit in those patients who had the most severe disease involvement. In terms of reduced dose glucocorticoids, this was found to be non-inferior with respect to end-stage renal disease or death compared to standard doses. And importantly was that reduced dose glucocorticoids resulted in fewer serious infections, therefore demonstrating that patients could do well with less glucocorticoids. So along those lines, our final question. Which of the following is an indication to consider avacopan in GPA? Newly diagnosed severe active disease, non-severe disease relapse, as an alternative to rituximab for remission maintenance, a patient in remission having prednisone intolerance, or all of the above. All right, well, this is interesting. So, majority is saying all of the above. All right, so let's talk about avacopan. So, I was actually looking for newly diagnosed severe active disease. So, avacopan is a small molecule inhibitor of the complement 5A receptor. And after 2 promising phase 2 studies demonstrating safety and also the ability to reduce glucocorticoids, this was the focus of a randomized trial in 330 newly diagnosed or relapsing patients with severe GPA or MPA. Patients received cyclophosphamide or rituximab either in combination with standard prednisone and a placebo for avacopan, or alternatively avacopan and a placebo for prednisone. What was found was that avacopan was non-inferior to prednisone for inducing remission at week 26. It was superior to prednisone for sustained remission at week 52, and the safety of avacopan was favorable, with the main toxicity to monitor for being hepatotoxicity. Now, there are a couple of things to keep in mind with this study. Although certainly this was less glucocorticoids than had previously been possible, this is not glucocorticoid free. This was also a heavily renally based population, with 81% having glomerulonephritis and only 44% having upper airways disease. So there are some important future questions about whether avacopan will be equally effective for all disease features. What should be the duration of avacopan as the clinical trial stopped treatment at 52 weeks? What about its use for severe disease and use for maintenance in place of other agents? But on the basis of this clinical trial, avacopan received FDA approval in October of 2021 for the indication of patients with severe active ANCA-associated vasculitis in combination with standard therapy. And this remains the only setting in which there has been published experience. So how do I use avacopan? Again, I use it in the setting of active severe disease in patients who are either newly diagnosed or relapsing. I'll begin cyclophosphamide or rituximab together with glucocorticoids, and ideally try to initiate the avacopan as soon as possible in the active course, followed by a rapid glucocorticoid taper. Now, I just want to briefly touch on the fact that not all treatment is involved around immunosuppression, and there are important non-medical management options with upper airways disease. Humidification, moisturization, and irrigation are critical in patients who have sinonasal disease and are often underutilized. In the setting of patients with subglottic stenosis, an intratracheal dilation technique done in coordination with our ENT colleagues is important because this is typically unresponsive to systemic immunosuppression due to fibroblastic scarring. Optimizing patient outcome also goes beyond immunosuppression. In addition to the use of evidence-based treatment regimens, as we've discussed, monitoring is incredibly important, looking for disease relapse, treatment toxicity, and the emergence of other diseases. This is accomplished by our physician visits and labs, and what I monitor is complete blood count, chemistries, a marker of inflammation, and very importantly, the urinalysis. Looking out for cardiovascular health as well as general health screening. Aggressive use of prophylactic strategies is also very important for infection with pneumocystis prophylaxis, the use of non-live vaccines, preventive measures against other medication-specific side effects. One of the most critical things we do clinically is trying to differentiate active disease from other things that can look very much like this, and then, of course, the important role of patient and family education. So in conclusion, in 2023, GPA is a treatable disease and associated with long-term survival, but there remain ongoing concerns with relapse, treatment toxicity, and organ damage, therefore the need for ongoing research. Essential takeaways when considering induction treatment for active disease, you want to first determine if this is someone who has severe or non-severe disease, where if you have someone with severe disease, you're going to be deciding between cyclophosphamide and rituximab plus glucocorticoids, and considering the addition of avacopan as soon as possible with a rapid glucocorticoid taper. In the setting of non-severe disease, you have the options of methotrexate or mycophenolate in addition. After remission is achieved, you want to pursue a maintenance regimen, and that's whether it's either cyclophosphamide or rituximab. We talked about rituximab having fewer relapses, but still the utility and availability of conventional agents. Do remember the use of non-medical treatments for upper airways disease and pursue aggressive monitoring and prophylactic strategies at all times. So I want to thank you again, and I look forward to answering questions on the panel.